Hello, you're listening to Jodie Brunning of PSGR NZ, and today I'm talking to Anna Goodwin. Anna is a retired oncologist and she's working with cancer prevention. I'm going to let Anna do the talking right now because what she's doing is quite complex. So Anna, let's start with your medical background, your university, your years in clinical oncology, such as, for example, were you a generalist, and when did you shift into particular specialties?
Well, I made a somewhat pragmatic, cost-based decision about my medical school, but I have no regrets, and I think it was actually a very, very good decision. I happened to be in Tulsa, Oklahoma for my undergraduate work, which was at Oral Roberts University, because I thought I wanted to be a medical missionary at the time. So I had friends in Tulsa, Oklahoma, and I was an Oklahoma resident, and that enabled me to go to medical school at the local osteopathic medical college. So osteopathic medicine is slightly different in America than it is in New Zealand. It hails from the philosophy of Andrew Taylor Still, who basically branched away from mainstream medicine back in the 1800s and decried the role of harmful drugs that was being put forth by Benjamin Rush, who's known as the father of allopathic medicine. And the medical school there taught a systems of biology approach, which layered all of the different concepts of physiology and different organ systems. And we actually did have a very, very good nutritional biochemistry course, which has served me very well to this day. And I'm very, very grateful for Dr. Martin Benchbach for his role in my education. So I finished near the top of my class, and I went to medical school knowing full well that I wanted to be working in the field of cancer. Osteopathic trainees normally go into a general practice, and the whole mission is to go into the underserved areas. I kind of carried that into my decision making, but so I ended up going to do an internal medicine residency at the University of Tennessee. That was a pragmatic choice because my adopted father had a heart attack, and I felt that I needed to be closer to home. So I finished that. That was a level 1 trauma center in Chattanooga, and that was very, very good training, and it prepared me well. And I had wonderful oncologists there, and since I knew I wanted to be a cancer doctor, I did all of my electives in oncology. So when I did my fellowship at the University of Alabama at Birmingham, I basically did about a year of fellowship, and halfway into my second year of fellowship, there was a mass exodus of faculty. So they made me junior faculty because they needed someone to take over, and I enjoyed teaching. And so from the time I was 1.5 years into my 3-year fellowship, I was an instructor and then became an assistant professor. I was known at that time as Elizabeth Lowenthal, and that's still a name that I have on all of my registrations and state licenses in America. I worked at the University of Alabama at Birmingham as an assistant professor, was part of an interdisciplinary sickle cell grant that was successful through the NHLBI. And my mentor there was Dr. Joseph Percal, who has over 300 publications, and he's now at the Huntsman Cancer Institute in Utah. So I felt like I got really, really good, solid training with these mentors. And I had a particular interest in sickle cell and HIV-related malignancies at the time. And that was kind of pragmatic too, because no one wanted to study those things. And so it was ripe for grantsmanship. So I wrote some good grants, and then due to some political things at the time, some of my grant money was taken off me in order to fund someone else and do away with my social worker, and that was a deal breaker. And when you make a threat to leave, you can't make it a bluff. So I basically went into private practice for the next 15 years, and that was I was very much a generalist. But just as in New Zealand, we have certain major tumor streams that affect more people than others, and in particular bowel, prostate, breast, lung. Those are the big four in America, as in New Zealand. And there's also quite a plethora of lymphoma, myeloma. Those are all very good. So very big in terms of incidence and mortality. And so when I got rather burnt out on the whole healthcare sector in America with all of the Medicare reforms, and it was getting increasingly difficult to be the manager as well as the clinician, which they don't train us for management in medical school. That was something that I had to learn on the fly. I didn't enjoy it, but I was successful at it under the circumstances. So I saw a locum job offering at Waikato Hospital and decided I wanted to see how the socialized medical model actually worked. And I didn't know at the time, but they actually separate training or practice patterns over here into either medical oncology or hematology. In America, I was doing both and had trained in both. So I took a medical oncology position at Waikato Hospital for 6 months, and that put a little bit of strain on my marriage at the time. But I was determined at the time that I was going to become a New Zealand citizen and make a go of it, because I wasn't happy with the way things were going in America in health or otherwise. So I took a couple of more locum contracts, and in 2011, my marriage dissolved. And once I finished up my last contract at Waikato, I elected to change my name because I felt like I needed a new beginning. And it was the first time in my life that I didn't have patients and family and friends expecting me to be my American name. And so I had a dear friend named Doris Goodwin, and she never had children and kind of adopted me as her daughter. So I became Anna Goodwin, and then I started a private practice at Braemar Hospital, and then one at Southern Cross Hospital, and I also started a few integrative health clinics in New Zealand. And I've been very humbled by my patients in New Zealand, and they've really opened my eyes to a whole new way of doing things, because I realized when I had time to actually start analyzing these things that there is such a tremendous amount of information that can promote health and wellness in cancer patients. And so I started, I was the first oncologist in New Zealand to actually give intravenous vitamin C to my patients who were also on cancer treatment. And we were able to give that vitamin C intravenously to over 1,000 times using someone's portacath, which is the device through which they get their regular treatments. And it does have to be treated with care. It can't be done just by someone who doesn't have proper training. But with proper training and sterile technique, there's no implication for, no reason whatsoever why patients cannot receive intravenous vitamin C. So my practice, because everyone in New Zealand has access to a pretty good public system, my role as a private practitioner in an area where there were no other private practitioners at the time involved providing access to drug therapies and other options that were not available in the public sector. And one of the deficits that I realized is that no one talks about nutrition as part of their cancer consultations. And so that started making me extremely popular with the patients. And a lot of patients, I wasn't that big on IV vitamin C, but there was such a demand for it. And I thought, okay, well, we'll see if this works and how we can make it as easy as possible. And it became rather seamless, and it was very easy. It was a part of my consultation. I could see people leaving smiling, whereas they felt disempowered when they came in. They left smiling, feeling empowered, feeling like they could do this, even though they'd been sent home to die, told they had 3 months to live, and that was that. And some of these patients, we were seeing them live, 3 years longer, 5 years longer, 7 years longer, some of them that were told they had less than a year. And there's been very little in my life that's been more gratifying than that. And so I began to be sort of an oddity in New Zealand because I was the only oncologist that was talking to patients about nutrition. And so it became a very, very interesting time because the integrative community and the complementary community were doing a lot of things. Some of them didn't like me giving vitamin C because that was part of their business model. But then others thought, well, it's nice to have someone that's actually looking after the whole patient. And they realized that I wasn't really competing with them because they couldn't actually use the portacath. And we could. So, that basically, my popularity with patients was actually a big problem for the some of the political movers in New Zealand. And so I got a few vexatious complaints, actually just one vexatious complaint from a disgruntled colleague who viewed me as a competitor. And so that ended up with a sham review proceeding through one of the private hospitals, and the sham review proceeding was orchestrated by the hospital attorney who also worked at the medical council. And it didn't take too many dots to be connected before I realized that this was a stitch up. And so I had to withdraw my medical registration. And so that just meant that I was able to learn and school myself up more in integrative health and in the nutritional and environmental aspects of cancer. So after that, in 2020, I commenced finishing up my fellowship in nutritional and environmental medicine through the Australasian College of Nutrition and Environmental Medicine. I went on to complete a fellowship in the Australasian Society of Lifestyle Medicine. I've spoken at several international conferences on integrative oncology, and I now provide telehealth services using natural therapeutics and counseling, and I'm able to understand the risks that the patient is facing when they go into their mainstream treatment. I'm able to educate them about that, how they can feed themselves, how they can nourish themselves in that space in order to minimize their toxicity, and also, as we'll talk later on, to stop the cancer cell recruitment process. Because if one does not stop recruiting the cancer cells almost as quickly as someone stops their chemotherapy, new cancer cells are moving in, and that leads to the ultimate despair, despondency, and the patient just no longer can cope with more toxicity and treatment without proper nourishment of their body. So this has actually been one of the more gratifying eras of my life, surprisingly so, not economically, but in terms of professional satisfaction. I've had a great deal of professional satisfaction, and I see amazing people, and many of them just needed some hope to go on or to understand what was happening to them and to have some empowerment restored to their life. So it's been a very interesting, bumpy journey, but it's been an amazing journey.
I don't know any medical doctor who isn't in the clinical and the functional medicine space that does not know you and does not respect you in New Zealand. So you are widely respected, and I met you through the Physicians and Scientists for Global Responsibility because many of the members there absolutely respected you, and so since then you've been invited on to be a trustee. So we're hearing more and more about some of the little cancers, but the big ones are still can I say they're the killers? What is your experience in clinical practice?
It's a very important question, Jody. And the word cancer itself is the scariest of words to hear in reference to yourself, because people almost have an immediate recoil of, oh no, not me, I'm going to die. And so many cancers are not lethal. They're highly curable. And if they're not curable, then especially when people begin to approach their own wellness and secondary prevention aspects, I find that even if they're not cured of their cancer, they can live with it a really long time. Sometimes they get to die of something else. Sometimes it's the cancer that eventually does them in. But meanwhile, they can have a lot of good time to enjoy family and friends and sunsets and this amazing world that we have. So I think it's important just to focus our efforts on, you know, the most common cancers and why do they arise. And because many, you know, if you know, it's not that a rare cancer is not important, but many of the same things, if we are able to do some generalizations, many of the same things you'll see overlapping between different tumor streams. And we'll realize that all of these tumors, if we lump them together, they have something in common. They're the ones that you've asked about, primarily the lung, colorectal, breast, prostate, skin, they're all epithelioid malignancies. They have certain cell markers that are retained that tell us when we look at the cancer cell under the microscope or on flow cytometry or cytogenetics, we can know that that cell came from an epithelial derivative. And it just depends on how far we look back in its genealogy, so to speak, in its family tree.
And they come
And
under the
so
carcinoma group.
those are all carcinomas. The sarcomas are fairly rare. They come from a mesodermal embryonic derivative, the mesenchymal cells, and those tend to be, they don't go through mitosis as often, but when they do go through mitosis, it's fast, furious, and hard to stop. Because when we are in our mother's womb, we start out as as a little blastocyst, and it's the cells that are connected to the uterus that eventually form the fetus there. And so many of these things happen just without even, you know, everything is happening without the mother even knowing that something has attached to her womb, and it's actually growing like a cancer there. And about 1 trillion cells per week are synthesized in that space. And we actually have something that resembles a human after about 10 weeks. So all of those cells that started with that one cell going through mitosis trillions of times in a very short time span, you could imagine that as one cell passes the baton to the next generation, and that becomes more specialized, more specialized, more specialized, organs are formed. But it all started with the one. And so what I've begun to understand about cancer is that, and it's been understood for a long time, this is not my unique understanding, the more primitive of the cells have the greatest potential for spreading, and they're also, they like to go through mitosis under certain conditions. Mitosis is one cell becoming two. That's the cell division process, as you would know. So they're kind of slowed down when certain factors that are present during pregnancy are not present. We know during that time there's really not much circulation apart from what's being parasitized from the mother, and what's floating in that area without oxygen, and, you know, just whatever little amount of glucose can be achieved. So this is the condition that favors cancer. We often think that, you know, starving cancer is going to be the way to go. Well, that, you know, you can't really starve cancer without starving yourself in some capacity. The key is to be selective with your nutrition, because the cancer really is quite limited. And when we go back to those very primitive embryonic cells, they they can only they're only there because there's no oxygen. Once oxygen starts infusing the tissues, things get more and more specialized to deal with our oxygen laden environment. And but the more primitive cells, they actually get meaner. The more oxygen is taken away, the more anaerobic things become. It just causes sort of the amplification of primitive genes. And this is why, in my view, um, oxygen therapies might have a role to play because they actually promote autophagy in the primitive cell type. And so it's not necessarily, you know, the killing so much as it is the differentiation and the autophagy happening as a result of cell differentiation and the cells moving forward to a more specialized and normalized type as opposed to the primitive form.
So an autophagy is cell death.
Yeah, programmed cell death. And that's what people need to realize as well, because every single cancer cell has its own programmable cell death pathway. And most of that is around a molecule called P53. P53 is, part of the oxidative burst phase of cell killing, and almost every cancer has a mutated P53. So when we can get P53 signaling pathways working, the cancer cell can just go kill itself. That's its natural biologically programmed response. We don't have to do anything. And it's just a matter of helping the other cells around the cancer cell understand they have a role in the structural integrity of the individual. And then the cancer cell gets to actually caring what's happening around it. And that happens when our vitamin D levels are good through a molecule called E-cadherin. We must have E-cadherin in order to have all of our cells function. And when you are low in vitamin D, which is central to that E-cadherin pathway, nothing works like it should. And so these are all very simple hacks that send very powerful messages regarding cell coherence, cell signaling pathways, and the cost is relatively small and not very toxic in the end. And so I found that it's really quite powerful just to get my patients on a healthy vitamin D level, and also making sure their methylation pathways are working and they're not adding to the toxic burden or the basically the processed foods and inflammatory things in our diet that we know, and these are well described, but largely ignored by the medical profession.
Yep.
So these very common cancers are almost always epithelial cancers. They're almost always adenocarcinomas. There are a few squamous cell carcinomas in there, also epithelial derived. The adenocarcinomas generally are from the subcutaneous glands or subepithelial glands in the colon, or the ductal cells of the breast, the ductal cells of the prostate, and so on. So those are the two big big family trees, and the rest of them are somewhat more rare, more unusual. And the lymphoid and blood forming elements, those come from a different lineage as well.
And can you talk a little bit about metastatic processes? And here's a simple question: can a carcinoma turn into a blood cancer?
Not usually. There are things called carcinosarcomas and things that can have multi-lineages. You can have a biphenotypic B and T cell lymphoma, and that generally means that they've heralded from a more primitive origin in order to have two mutated pathways of differentiation being manifested in the same tumor. They're a bit of a chimera, as it were,
Yeah.
For lack of a better term.
Okay.
But carcinomas don't usually form blood cancers. Sometimes we get secondary malignancies from cancer treatment. Some secondary leukemias can arise from alkylating agents and topoisomerase inhibitors and various things that can cause a small incidence of secondary leukemias after treatment of epithelial carcinomas.
Oh, and surgery?
Surgery is very interesting. I think we don't realize that many normal looking people are walking around with cancer. And by the time most oncologists see a cancer patient, they've probably been growing a cancer for at least 2 years, if not 5 years. And we know that the time it takes from a pre-malignant polyp in the colon to the time someone develops a colon cancer from that polyp is about 15 years. So there's a lot of opportunity for early detection, and early detection is key for surgery. The problem is that at any point in the life cycle of the malignant cell, it can become disengaged from the primary tumor, and it can go into the lymphatic circulation, the blood circulation, and it can basically spread anywhere. We know that, this was a really mean study, and I hated the whole idea of it. It was done probably 20 years ago, but on a series of breast cancer patients that had stage 1, they did double bone marrow biopsies on these patients, which would have been, I would have struggled to get that through an ethics board, but they did polymerase chain reaction on those bone marrow samples and found that 40% of stage 1 breast cancer patients actually had breast cancer DNA in their bone marrow. So if that was used as a criteria for metastasis, we would have been treating those very early stage women as having stage 4 disease. But we know that 40% of them were not going to manifest their disease. So that tells you that even though these little things might be frequently migrating and settling in various places, they don't often become a cancer. We know that stage 1 breast cancer has less than a 10% likelihood of developing metastatic disease or manifesting that. So these little cells can go places and travel. They don't always become cancer. So I think the biggest research question in my mind that's not being addressed is, what was the cancer cell doing before it decided to start growing again? And that's the space where I like to put forth non-toxic, relatively inexpensive modalities that we know are going to shut down the injury signals, nourish the body. And so that's really the important space, if we can actually get people doing these things and realizing what a powerful place this is. Because if we don't keep stimulating the process that led to the cancer phenotype, we don't necessarily have the manifestation of a metastatic process.
Yep. So it comes back to the I guess we can even call it terrain theory.
Yeah, it's terrain. It's host factors as well as the biological aggressiveness of the cancer and its own intrinsic potential, and is it still responding to its own P53 signals, or is it getting signals that are encouraging it to go through mitosis and begin, invading the tissue that it's surrounding,
Yeah,
or that's surrounding it.
Yeah, so basically we could say that cancer kills by growing into key organs, nerves and blood vessels, and interfering with or impairing their function. That would at base be correct.
Yeah, I think that's one aspect of it. I would go just a little bit further, because the cancer cell is a cell that's in the wrong place at the wrong time. It doesn't belong there. And it's a klutzy cell. It's not intelligent. It's not Darth Vader. It's basically a little bull in a china shop, and it doesn't really know what it's doing. It's a baby throwing a tanty in the supermarket. It causes everything around it to get upset, and it causes inflammation. So one of the more common and preventable things that causes death in cancer patients is blood clotting. So patients often die of secondary blood clots. If someone lives long enough with their cancer, if the cancer is uncontrolled and the cancer doesn't invade a major organ that causes a life-threatening emergency, the pathway then becomes one of starvation, because the cancer is so demanding with its calories, and it absorbs calories, especially glucose calories, faster than any other tissue in the body. And so the other tissues just begin to starve, and this is the mechanism of cancer cachexia. And so this is where strategic nutrition comes in again, because we know that cancer cannot live on ketones, whereas most of the body's normal tissues have been programmed to live on ketones. As a species, we've had implied fasting for sometimes days and weeks at a time before we were able to emerge from our cave or catch a beast and go hunting and gathering our food again. So intervals of fasting and starvation are hardwired into our DNA. Our caveman ancestors didn't eat 3 square meals a day, and that's probably not really that good for us at the end of the day when we explore these things a bit further.
And cancer cells are multipotential stem cells, that would be correct?
There's a spectrum, and that implies the aggressiveness as well as the chemotherapy resistance. Once a cell has gone down, you have your circulating stem cells in the peripheral blood. Many of these are going to have, epithelial markers. There's a stem cell to repair anything that becomes injured. This is the amazing thing that I think people need to really understand, that most of the cellular and molecular processes that allow a cancer to happen are normal processes that have been where a cell just got it wrong, it got a mutation, it got injured, and the mess wasn't cleaned up. So we have a stem cell that is circulating in the peripheral blood. That's going to have more of an embryonic feature. It's going to carry more programs with it. So
you called it a blueprint.
It's a blueprint, as it were. So when we have a breast cancer that starts in breast tissue, for instance, that's such a very common cancer in women. We're going to have some transformed fibroblasts in that, the transformation of the cells around that. Anything that causes injury is going to cause the fibroblasts to become more unstable. They're going to be ready to begin more cross-linking tissue repair. They're going to be moving in to create a layer around blood vessels that are injured. So all these things exist as injury and wound repair mechanisms. So we get a ductal cell of the breast that becomes injured, too many endocrine disruptors, hard knock to the breast, stress in the lifestyle, pesticides, whatever led to that cancer. Or there might have been a predisposition through an inheritance, but that accounts for only about 5% of cancers. So almost all cancers are multifactorial. So that cancer will exist, and it might sit there for a while before it's detected. We know, most cancers, if you have a 1 centimeter tumor, that generally means you have about 1 million cancer cells in that 1 centimeter. And so that's really, the cancer is kind of well on its way by the time it's even 1 centimeter, and that's when it becomes more detectable. So there are going to be some stem cells in that tumor. The natural nature of a stem cell is to circulate, because it's going all around the body. Oh, does somebody need me? It's asking that question. Is there an injury? So it's going to detect an injury or an inflammatory signal. It's going to detect anything like that where wound repair mechanisms are being turned on, and that's where it's going to go. And so when we look at patterns of metastasis, people that have, back arthritis, all of those, and people that have, vessel disease, and other things, that's oftentimes where the cancer goes. And, digestive cancers love to home in on the liver. That's where they seem to find their anchoring, and it's also the basis of where the circulation goes. So there's a lot of things that determine where a cancer turns up. We know that the endocrine responsive cancers tend to end up in the vertebral bodies, in the spine, and you could even bring that back to the linkage with cancer and obesity And almost everyone who's obese has spine inflammation from chronic injury of, the compression of their vertebrae, the lipping of their vertebrae, and we have that inflammatory process going on. So, this is a very easy site for those cancer cells to turn up, unfortunately. And so this is where lifestyle modifications really play a big dividend, I think, in secondary prevention for
And
various cancers.
and you could, because you've said it's no accident that the cells frequently needing replacement or are prone to injury are the ones most likely to form a cancer.
That's right, because they're having to do the work all the time. The sarcomas that normally they're derived from bone, muscle, cartilage. Those are not things that go through a lot of mitosis. The more something goes through mitosis, it's like Schrodinger's theory of the atom. The more rotations something has, the closer it's at the nucleus, the more collisions, that's just how it all works. So if something's not going through mitosis, it doesn't get the chance to express its screwed up, mutated, gene expression. But something that's having to replace itself all the time. And this is why, things like colitis are associated with higher risk of colon cancer, that you're having a constant turnover of your cells. There's a lot more activity going on, so there's a lot more room for error. And that
this is where
seems
you
to be just
come to inflammation.
correct. Because all
And
of the
so,
inflammatory things are going to accelerate the cell division, cell destruction. There's a lot of oxidative intermediates there that are going to cause the need for constant replacement. So it all just fits very neatly together, that when we start addressing the inflammation and nutritional aspects,
so you
people just
so
do
you
better.
have a theory. You theorize cancer as a response to injury, and I guess your entire practice is now based around this theory that injury repair response that did not get turned off because of an environment that's created ongoing growth and inflammatory signals. So that's, and the idea, if we go back to 80% of adult cancers being adenocarcinomas that are arising from a glandular lining of the epithelial cells, that all sort of starts to make a bit of sense.
Good, good. Yeah. I want it to make sense because I believe that healing is very attainable and it doesn't always have to be drug-based. And it actually starts with those day-to-day boring decisions that you make about what am I going to have for breakfast? What am I going to have for dinner? And those questions that we often think of these as boring and unimportant things because we just want to get on to our next really important thing. But there's, when you're managing a disease process like this, I would argue that there's nothing more important than changing your soil, creating soil that's going to grow healthy cells, or cut down on the weeds at least, and to basically restructure your body so that it's functioning in health. And and that's how, one little boring decision at a time pays
Yeah.
off 3 years down the track. It takes about 3 months, maybe not quite so long. Some epigenetic studies in the laboratory have shown that epigenetics can be altered with 6 weeks of changes.
And what does
Where
epigenetics mean?
epigenetics is what's around the gene. And so there are a lot of things that determine what genes are going to be expressed. The interesting thing about the Human Genome Project was that it ended up being a bit of a fizzer because we thought that was going to be all the answers once we got the gene sequence of the human genome. But it turns out that we're far more than just the sequence. There's folding patterns, there's little sulfhydryl groups, there's methyl groups, there's acetyl groups, there's a lot of different things that determine whether a gene is going to be expressed or whether the transcriptional enzymes are going to have access to that, whether that will be incorporated into a ribosome and manage to, go into the next generation of cells. And there's a whole lot of matters that are we're just beginning to understand. And the problem is we're changing these things through CRISPR and genetic engineering and various things that we have no idea how this is going to ramify on future generations or even this present generation in terms of how our bodies regulate
Yes.
themselves.
Yeah, there is the potential for a heritability factor. And so
Correct.
we know that with the gene doesn't change much, but DNA doesn't change much. But over time, what changes are the instructions. And so that's the epigenetics changing how the gene functions. And that's probably how humans have been able to adapt to lots of different environments.
That's right.
And so it's really important to understand that these instructions can create the terrible environment that promotes cancer. But and what you say is it's a restoration of communication avenues to remove and reduce the injury and the growth of the inflammatory signal.
Correct.
That's correct?
That's correct. Because if we're not sending injury signals, we're no longer transducing that signal to the nucleus and saying, hey, we need more of this particular type of cell to come over here and create a new breast, even though I'm sitting here in the spinal cord and you're recruiting more breast stem cells into that space. And that's actually what's happening. And when I tell patients that, they realize that their cancer really is stupid, because I think people think their cancer is smarter than them or smarter than their body. And we have to just accept that this is just a biological adaptation that's gone wrong. Their body made it. It didn't move in to try to kill them. And if their body made it, there must be a way of reprogramming that as well. And I think that's a potential that people don't think about. And, I think going forward, I hope we will, because I think that's really where we need to go. We don't need another, kinase inhibitor or whatever that no one can even pronounce anymore. I mean, the design of the drug is all about an intellectual patent of a specific molecule. But Mother Nature has, if we don't change the soil, as it were, the natural selection process dictates that Mother Nature will just move over here and do it another way. And that's what I mean by, taking your foot off the gas pedal as you're applying the brake. So pharmaceuticals become a very finite brake, and they're all about intellectual patents and all about shareholder profits. And some of these drugs work really well, and I'm glad that we have them, because they give patients a bridge while the patient is coming in and doing the hard yards of changing their biology a bit so that they're no longer recruiting. And those patients, in my experience, do remarkably well. I love getting people, to understand these principles early in the piece so that they are actually not gaining more recruitment. And we also have found that certain dietary factors are going to increase the sensitivity of certain chemotherapies, which is amazing.
So this is really interesting. So you're saying that you've got the bridge, which can be surgery, radiation, chemotherapy, and then while this part of the bridge is being built, you're also putting the foundations in, which is good nutrition, cleaning up your act so that you don't keep growing cancer. Then you get through that 3 to 6 months, and then you can start, you're basically creating a foundation that's not inflammatory. So you've had that transitional period.
Right.
But in addition, sometimes it's beneficial to change your diet, because then you will respond to cancer treatment better.
Absolutely. There are certain things in curcumin, for instance. Studies have actually shown that it improves the sensitivity to paclitaxel. And we know that because of the uptake of certain nerve poisons in the peripheral nerves, that when someone's on a ketogenic diet, the nerves aren't taking up as much poison because they're trying to extract glucose. And when someone's got a low glucose, the nerves are more protected. So I've got patients that are able to keep getting some of these neurotoxic drugs for years on end without getting peripheral neuropathy, whereas many patients who aren't changing their diet are able to get one round and they've got permanent peripheral neuropathy. So it basically allows you to have more options when we understand how all this works and fits together. And, coming back to your question about surgery, surgery is a very important thing, and it can actually cure very early cancers. But if we are not judicious in who we select for surgery, if someone's got a borderline resectable cancer and the cancer has already breached the borders of, a certain organ or basement membrane or whatever, sometimes it's better to give those patients chemotherapy up front, or sometimes it's better to skip surgery. Like for some men that have very advanced prostate cancer, for instance, that's invaded seminal vesicles, gone beyond the capsule, high Gleason score, that means very mitotically active. Those men are probably not going to be cured with surgery. And then we have the injury that goes with the surgery. So when we have a high grade cancer that's locally advanced and we go in trying to resect it, we've created a whole region of injury signals. And so, of course, that cancer comes back there. Of course, it's metastasizing. We have systemic inflammatory mediators that are sent throughout the body. And so it's hard for us to get patients before surgery, but I used to think that was a really advantageous place, is when I had a locally advanced, a person with a locally advanced cancer, to be able to bring them into anti-inflammatory diet plan, get them on some chemotherapy, and oftentimes we can shrink the tumor down by 50, 70, 80%. Sometimes it'll completely go away. And then that's creating new dilemmas. If you completely have a cancer go away, do you even need surgery then? So there's a lot of advantages to standard therapy. In the prostate cancer case, it's not known to be a particularly chemotherapy sensitive disease, but, we do use chemotherapy for prostate cancer in a certain subset, but, radiation therapy can contain cancer in that region without creating the injury signals. In fact, it just causes things to scar down instead of actually, opening up the blood vessels and making it easier for those malignant stem cells to go circulating throughout the body.
And is that called the dandelion effect?
Yeah, that's I don't like that, but everyone gets that. That's kind of what happens with metastasis. Everyone can identify with, how random that event might be and how we would want to keep things contained locally, because it just becomes that much more difficult. I don't worry about dandelions in my yard, and because if you dandelions are there to basically detoxify the soil. So I don't worry about dandelions, but a lot of people do, and we go after them with poison and all the rest. So it's a relevant model for cancer, but it all depends on how you think about the dandelion as well.
And so the what we've been discussing, if I'm getting this, the EMT transition is the epithelial mesenchymal transition, EMT, and it's when epithelial cells start moving around and sort of, are they becoming more like stem cells, or like that you've said this relates to a degree of stemness?
Yeah, EMT cells are cells that are early in the embryonic phase, before we have a well-defined endoderm, ectoderm, and mesoderm. So those are cells that are sort of in that transition. So they are early embryonic cells, and they're the ones that circulate, and they don't have the integrins and adhesion molecules that help them stick together and form an organized tumor. What they do is they respond to injury. So they come in, they get an injury signal, the vascular channels are open in an area, they go into a tissue that's injured, and then they have the capacity, now that they've found a place to hang out, they differentiate into the epithelial malignancy there, and then it starts going through mitosis, making a clone of breast adenocarcinoma cells, for instance.
And so they have receptors, EMT cells have receptors or preferences for where they want to go.
Normally areas of inflammation. And I think if we study these things, there are patterns, and they tend to, go to places that are, familiar to them, but EMT cells in general lose their polarity. They don't know which end is up. They're sort of random cells that are floating around, and it depends on, are the blood vessels nearby weepy, which we know happens from inflammation. We get the rubor, tumor, the swelling, the redness. All of these things are indicative of very open vascular channels, and so and that causes the pain. And so this is an area that's attractive to cancer cells.
And so
does that make sense?
Oh yeah, it absolutely does. And so, but you're seeing the patterns in your notes. You'd said that the endocrine positive prostate and breast cells like to go to bone, in particular the pedicles and the body of vertebrae, due to the rich vascular supply.
Yeah. And then there's, coming back to the lifestyle, like we said, we know that people that are, and you don't have to be heavy to get metastasis to your spine. Many people are not, but these are, I think we're still beginning to understand why certain of these cell types home in on bone and particular areas. There's some cancers that very seldom go to the brain, but some we're surprised if they don't go to the brain. For instance, melanoma and small cell. Those are neural crests from neuroectodermal embryonic lineage, and those cells go to the brain because their cousins are up there. They recognize this rich milieu of neural ectodermal tissue that's there, and it feels familiar, and that's one of their favorite places.
And because your notes are fantastic, small cell lung cancer as well.
Yes, small cell lung cancer, also derived from neural crest.
So we haven't yet just talked about the entire digestive system, because we're seeing cancer all along the digestive system and of course the liver. And you've said that for example, the GI EMT cells, from the colon, the stomach and the pancreas like to grow in the liver.
Correct. And that's a matter of the circulation as well. They're somewhat pragmatic. They're going to be going into the liver circulation through the portal circulation, which drains the GI tract and the biliary tree. And it's important to realize that all of these embryonic layers are manifest in all of these organs, because the gut has neural tissue as well as epithelial tissue, and also vascular tissue, which would have come from the endoderm. So all of these things are, it's phenomenal that all of these cells knew exactly where to go in order to create continuity from north to south, and to allow us to live and breathe and eat and think and adapt constantly to an environment that's ever changing. And there's a program in there that allows it all to happen, and we're allowed to recover from injury that would otherwise have been lethal. And it's all a very, very delicate balance between oxidation, antioxidation, degradation, programmed cell death, regeneration, and we are fearfully and wonderfully made, as the saying goes.
You made a comment, and I really appreciate this comment. You said the science of cancer knows that it's an injury response, but the clinical management of cancer has not yet figured this out for the most part. Hence, no one is instructing the patient on how to take the food off the gas pedal, for example. So what would you say is the position of most oncologists hearing what we've been discussing today?
Unfortunately, most of my colleagues would say that it doesn't matter what a patient eats, and their focus is how to get the drugs into the patient, and they're going to inform the patient of the risk. They'll be mindful of the to manage the risks as the treatment goes forward, and they're going to follow whether the cancer grows back or not. So they haven't recognized oftentimes that the person who manifests the cancer has brought a lot on their journey to that place. Oftentimes they are emotionally injured. Oftentimes people have decades of emotional stress that they've repressed and they've held and not dealt with. And the repression causes a blockage. If we look at the energetic mechanisms, the energy of that various, energy center is blocked. And energy healers talk about this, and I'm very open to that understanding because it so resonates in clinical medicine for me. So I oftentimes help patients understand that something that has happened to them caused the start of this process, and emphasize the importance of healing that. And many people are open to spiritual healing. Some want to call it energetic healing. I don't try to proselytize anyone. It's just a matter of understanding that we are multidimensional beings of thought and energy and mass, and all of these things need to be engaged in the healing process.
Because this, of course, it's not considered scientific. Clinical trials are very expensive, and they're really only embarked upon if there's going to be some sort of financial return. And so we need to understand that the evidence for what we're talking about is N equals 1, and it's from observational studies, and that's very valid. And and one of the reasons it's valid is because it provides an evidence layer, but we're not actually talking about toxicological drugs here. We're not talking about experiences that if they go wrong, that's called iatrogenesis, you're going to be harmed. So this is just as valid. And so when I think about someone that is working a 40 to 50-hour week and they've got poor nutrition and they're exhausted and they're not sleeping well and they feel terrible when they wake up in the morning, these conditions are salient, and they're part of creating the body's, the terrain that then makes you more vulnerable to some form of chronic illness. But a precursor can be inflammation. That would make sense.
Oh, absolutely. It's all interrelated. It's all interrelated. We know that, the stress and high cortisol and acopia and poor sleep, and we make our melatonin when we sleep, and melatonin is very important for immune function as well as autophagy of cells and our also regeneration. And so these very critical pathways that are disrupted by our modern important lifestyle, where we're suppressing our pineal gland function right up until midnight when we turn our devices off, and instead of perhaps having face-to-face conversations with family, reading an actual book that doesn't involve an LED screen, and just some of these quick hacks, and getting rid of the alarm clock that's blinking in your bedroom, and all of those things are just very quick hacks for restoring sleep. And we know that when people exercise regularly, even 30 minutes 4 or 5 times a week, they almost all of them improve their longevity from any cancer.
We know that oncologists don't have much time to review the scientific literature. And I know, for example, that medical doctors in New Zealand have attempted to say, I want to prescribe nutrients, and they've been told, no, you're a medical doctor, you can't do that. So as a conservative profession, and I'm very open to oncologists emailing psgr.org.nz, this is and info@psgr.org.nz to actually tell me I'm incorrect, but I believe that, or I understand it's a very conservative profession. So if oncologists start saying, I think your vitamin D should be this level, your vitamin C, where is your magnesium, selenium, and we might talk about this in another interview, they risk, if being reported, if there's a patient that's conservative that doesn't really want to address that, they risk being reported. But the problem is they're in a rock and a hard place because they're used to using the clinical evidence. Well, there's no clinical trials. And the other problem is that am I correct or incorrect, that the nutrition education is minor. You'll probably spend more time as a medical doctor studying toxicology than you will nutrition. So it's not a comfortable space for a very conservative profession to be in. Am I correct there?
Oh, you're absolutely correct. And the literature is very replete with studies on nutrition, but it's sort of a siloed mentality that, people that are selling vitamins or in the natural health world are going to be more knowledgeable about that. And I was very, very, I loved my education through ACNIM. It was just fantastic. I would love it if it was incorporated in all medical schools.
So that's
But
the
we know,
Australian College of Nutrition and
yeah,
Environmental Medicine.
correct. But that type of knowledge has been basically, it doesn't generate money for the big corporate players, and that's been a factor since the Flexner report of 1910, and that was funded by the Rockefeller Foundation, the Carnegie Foundation, and these big players that, doctors basically have to, yeah, that started the trajectory of modern medicine being sort of the focus being drug therapies. A drug for every disease was the aspirational model.
And it was difficult, in that environment. Would it be difficult for a medical doctor to use iodine?
Oh, absolutely. I've been absolutely vilified by some of my colleagues, and that was one of the aspects of the sham review proceeding. The reviewer didn't like that I prescribed vitamin D and B12 to my patients, even though my patients were doing very well and they could demonstrate no harm. And all of my patients were the ones who, or most of them, had been sent home from the public sector and told there was nothing else that could be done for them, and they were living long and living well. And so you would have thought that that would have been an incentive to say, wow, how can we help people? But it became an incentive to vilify me. And so I realized I just had to find a different place to practice, or a different
and
model.
and this becomes really, really crucial for people, because what you have been able to demonstrate, and with N equals 1, is patients that are living longer for a stage 4 cancer, say pancreatic, than they would be on medical treatment alone.
Correct. I have a couple of pancreatic cancer survivors who have been living 6 and 7 years with no surgery, who were diagnosed with stage 4 disease in 2016. And it's not me. It's using the first principles and understanding how the body works, how nutrition works, and putting it together. And the literature that many oncology colleagues would reach for is some of the literature that shows that the overutilization of supplements actually is correlated with a bad outcome. Because a few studies have been done that utilized high doses of beta carotene, for instance, and it turned out that patients who did that actually did much worse than people that didn't take supplements at all. We know that certain chemotherapy drugs are going to be abrogated by folic acid. We know that some cancers will actually be prevented by folic acid. But I think the real issue is knowing when to use what and in what setting. And patients cannot be expected to find their way in that space on their own, because each cancer is in many respects as different as the person who made it, and it requires an understanding of the person's diet, where they've been, their stressors, their strengths, and all of those things that actually they bring to the table as part of their healing. And what are they willing to do? What does their budget allow them? They can't afford organic food, but maybe we can help them choose some healthy vegetables and some simple supplements and a different way of thinking about what's bothering them.
So talk again for everyone about stopping that car.
Well, I think it comes down to the natural selection. When the process of natural selection involves, when we have a certain, stimulus, resistance, whatever, if we are driving something towards a certain place and yet we're trying to stop it over here, we're not going to get very far. And so it's very, patients understand the when they're trying to stop their car, they want to take the foot off the gas pedal, and the gas pedal is driving that cell or the cancer phenotype to make more of itself, to go through clonal expansion in response to injury and inflammatory signals. We know that the immediate early genes, Jun and Phos, those are direct injury signals. Well, that's also going to be telling those stem cells, come over here. Let's start a new settlement. And so I think those are, very important and easy things to work on. And there's a lot of information now about plant-based diets, and we could discuss that. But just in general, understanding that a lot of the intellectual patent rights that are related to genetically engineered species that are appearing in our food without our knowledge, and the genetically engineered oils that have been approved for general consumption, these are all pro-inflammatory. We don't have the tolerance, the immune tolerance that has taken thousands of years for the human species to develop to eat lactose, for instance. All of these things are related to what our ancestors were eating for generations. That's where we get the immune tolerance of the gut. And when we start putting proteins and gene sequences into our bodies that the body doesn't recognize as food, an inflammatory signal is generated. And this is why we're seeing, I think, such an epidemic of gut cancer, especially in young people. And certainly the other inflammatory things that have happened in the last 3 years have not been helpful.
From weaning, they might be fed Weet-Bix, that's been sprayed with Roundup.
The Roundup, I think it's important for people to realize that its original patent was as an antibiotic. So the antibiotics we know actually reduce the biodiversity of the gut microbiome, which is critical to the immune tolerance and the control of the inflammatory response in the gut to the food that we eat. Yeah. And because so many of our processed foods contain various residues, from triple herbicide resistant soy to triple herbicide resistant canola, and the pre-harvest desiccation with the Roundup.
The Australian Total Dietary Study in the 25th one, in the appendix, you'll see the degree to which cereals, biscuits, crackers, all the wheat-based products have not just glyphosate, but they have a combinatory effect of other pesticides and
Correct.
other ingredients. So this is part of the reason why perhaps, you know, eating less of this is good. Now, I do want to finish off by, so you talk about taking your foot off the gas pedal, because, you know, medicine is putting on the brake. But another thing that you talk about is the war on cancer. So we're finishing off with a discussion on the war of cancer. So if we're truly at war with something, as you've written, and victory is actually contemplated, would we feed and supply arms to our enemy?
No, I think clearly the answer is no to that. And this is why I think James Watson was skeptical when Richard Nixon declared war on cancer. Richard Nixon's war contemplated nothing to do with asbestos, vinyl chloride, benzene, all of these things that were known to be carcinogenic. And there was not much done with smoking until many years later. So the war on cancer was basically a declaration that a lot of money was going to be put through the National Cancer Institute for cancer research and drug development, but not one thing was going to be done to look at our environmental influences on cancer
This is in
development.
1971.
Yeah, the 1971, the war on cancer, and it's still an ongoing war, and we have more cancer than ever before. We have more people living with cancer than ever before, but we have not, by any stretch of the imagination, either cured cancer or stopped cancer. We've created more cancer because we have failed to to address the underlying causes, which I think must change in the next little while.
Well, I hope so. And, you know, in the next, we're about to stop now, but just as a final question, because I believe there's a model an increasing model being used in New Zealand for reversing diabetes through the reversal and pre-cure with the K groups, and that involves health providers that help coach and re-educate, providing emotional and practical support. And in government policy, they talk about cancer, and they suggest that the allied health, scientific and technical professionals, the AHPs, are mentioned as supporting people on the cancer process. But I can't see any dedicated effort that would follow the same lines as the diabetes model. It's really surprising that we seem to want to have a policy with cancer, but there is nothing there to provide a foundation or the infrastructure for people to actually shift the way they live and truly, you know, declare war on cancer by taking
Exactly
away the
right.
ammunitions.
That's it. They don't contemplate victory. And this is why many of our recent wars have been so ineffectual. They've simply wanted to spend money on the military-industrial complex without actually getting a victory. And this is essentially what we've done with the war on cancer. We want to spend money, and much of it goes to pharmaceutical shareholders, which we're glad that the research happens. But the more the individual is able to take on board the responsibility for their individual body, their individual food choices, and to realize that that's important, and they're not going to abdicate that to the government to look after them. The more we abdicate to the government to look after us when we're unwell, the more increasingly chronically unwell we will be.
Yes.
And the interruption, the disruptor, is to take a few matters into your own hands legally and lawfully and engage with your kitchen, have fun, keep your joy, and, you know that there's always hope.
Dr. Anna Goodwin, it's been such a pleasure.
Thank you. Thank you for having me, Jody.